that are creating their airway resistance are not in my office, not in my hospital, they're in their home, they're in their school. The fundamental reality is, yes, we can bring the exam room to where the patient is, but the real statement is that we have to evaluate our patients in their exam room, which is their home, their work site, their school. Very important concept. Now, second, what about the fact that with the electronic medical record, I can now bring the office to the practitioner, whether it's a physician or whether it's a nurse. And all of a sudden we say, gee, isn't that great? We're bringing the knowledge base to that practitioner. Well, I will challenge you and say, no, we're not. All we're bringing is the information, alleged information, that is in that electronic medical record, and we're bringing it to that practitioner. How do we know that practitioner is up to date? What is the system by which we all get brought up to date today? Well, one of the mechanisms is what we're doing right now. We're hearing somebody talk to us. And we're supposed to retain the information. Or we subscribe to a whole bunch of journals. And if we have the time, we actually may read the journals. Do you know what all of the studies on continuing medical education have shown in internal medicine? Repeated studies have shown it doesn't work. It doesn't matter how many times you go to continuing medical education lectures, you don't retain the information long enough for it to be valuable for your patients. That's scary. Now, is there a way, a very simple way, with the new technologies that we have 10 years from now to change that? Very simple. Think about this. All right. You are now all my patients. I now have all of your medical records in an electronic medical record in my office or wherever I want it to be. And all your diagnoses are in there. All the medications that you're on are in there. Your family history, etc. What if I developed a search engine, very simple search engine, that is constantly scanning my electronic medical records, all of the diagnostic categories, all of the medications that are being given for these diagnostic categories, and it's doing it anonymously, so you are not identified by this search engine. And while it is scanning my electronic medical records of you, it is also simultaneously scanning the world's medical literature. It feeds into the National Library of Medicine's PubMed database for peer-reviewed journals, and is constantly looking for new information that has just been published in the world's literature, immediately identifies it as something different than what I am doing for you, for your, say, multiple sclerosis, and immediately alerts me and you as the patient in a manner such that if it's just a minor change, it just gets redlined in that electronic medical record, and the next time I go to that electronic medical record, I've got a dynamic literature database sitting in your electronic medical record. If it is a major problem, think about what would have happened if we had that database. The minute the first findings with respect to a patient with arthritis who was being put on Vioxx who also had cardiovascular disease, if that system alerted the physician immediately to the fact that, by the way, there are 3 or 4 reports of early coronary thrombosis of individuals on Vioxx who were being given their Vioxx for their arthritis. A very simple system that I can see a Google or Microsoft instituted, and I, as a physician, would automatically subscribe to that service. And what if I paid $10, $20 a month for that service that constantly kept me dynamically updated in terms of my patient? And if I were the patient, I would want a similar type of dynamic search engine looking at my personalized health record and empowering me educationally to ask a question about one of the medications that I might be on. And I would be very willing to pay $10, $15 a month for that type of service. We could forget these kinds of conferences, or we can limit them, because you would have this conference in real time at your fingertips every single moment of the day. And depending upon the degree of need in terms of change of a practice standard or a very dangerous alert, that alert would immediately be identified, not when I just went back to the electronic medical record to take a look at it, but there would be an alerting system within my office or on my cell phone. Very simple way of approaching true continuing medical education in the future. That's one aspect. Let me ask you a question. And I apologize for this. I know there are a number of people in the audience who have heard me do this before, but I'm going to do it again because I think the message needs to be repeated. Sometimes you remember things when they're repeated. How many of you here have ever had a physical exam? Hopefully everybody's hand is going to go up. My God, this table has never had a physical exam. How many of you have ever had, well, let me change things around, given the number of hands. How many physicians are there in the room? And nurses? Okay, great. Keep your hands up for a moment. How many of you use a stethoscope to examine your patients? Interesting. Okay, all of those who use a stethoscope to examine your patients, how many of you have had a hearing test in the last year? Isn't that fascinating? And you listen to a patient's heart, and you don't hear anything abnormal, so you write in the chart, normal. Your patient should run out of the room. How in the world do you know you've heard what you should have heard? You know, 30 years ago, I could hear your mitral valve prolapse murmur. I'm sure I can't hear a grade 1, grade 2 mitral prolapse murmur now. So what would I do? I'd write down normal, because I'm writing down what I hear. How many of you have ever had a chest X-ray? Good, keep your hands up. How many of you asked your radiologist when he had his last eye test? By the way, how many of you have ever asked your physician who's taking care of you, what's between his ears? Isn't that fascinating? We go along, and I can point fingers at us because I'm one of you, so I can point this finger at myself. My patients come into my office, and they assume I'm providing them standard medical care. Well, I am. It's my standard. It's not the medical